And I suppose that imaging will also come in handy in the case of restenosis or situations down the road, because we don't know a whole lot about restenosis yet, and maybe either of you could speak to restenosis.
I like to classify there's early occlusion and there's true restenosis. Early occlusion are the patients who were treated perhaps several weeks to a month ago, and they thrombose off their jugular. And of course, some of these patients are, their disease was of a degree that it was going to happen no matter what we did. The best efforts do not yield a good result. A significant number of those patients, however, who have early thrombosis, early occlusion in a sense, I believe may be to suboptimal technique in performing the treatment. You should separate that from restenosis. Restenosis are the people who've had a good technique, who've had an angioplasty or a stent, and gradually over time, that comes back. And as to the rate of restenosis, what causes it, how to prevent it, how it compares to other venous vascular or arterial vascular systems, I think it's just much too early in the disease and the study of the disease to be able to answer those questions.
Well, just as a comment here, again and from the Glasgow meeting, that people like Ivo Petrov have now suggested that the early results of the Zamboni were that they didn't see stenosis in the azygos. That seemed to be somehow protected. They saw a lot of restenosis, and by that I meant restenosis of the azygos. They saw a lot of restenosis in the jugulars, maybe 50%. But Ivo was now saying with improved techniques and perhaps this related to the size of the ballooning and things like that, that they're finding that the results are now much less than 50%. So it's kind of interesting that the azygos seems somewhat protected from this, but the most threatened or most vulnerable is the area of the neck.
No, our rates of restenosis are they're much less. I can't quote an exact number, but they're, with the large balloons, with the valvuloplasty, with making sure we have adequate inflow and outflow from our pipes, they're very good. But at the same time, we're finding more and more that the azygos vein is extremely important. We'll find people, not an insignificant number of patients, who present to us with symptoms, whatever they may be, and their jugular veins do not have significant pathology. Then we look at the azygos vein, and there's all sorts of pathology there, which really is reinforced in our practice, the importance of looking at it and treating it when appropriate and how appropriate.
And in the event of restenosis, repeating the procedure, is that something that can be done 3 or 4 times if it need to be, or?
Yes, of course, something that's been angioplasty can be angioplastied again. Perhaps in an ideal world, we have patients who we find that there's a really good response to the angioplasty. And we put them under some sort of imaging surveillance, whether it be MR and or Doppler angiography, perhaps once a year. And we monitor the diameter and the flow in these vessels, such that once it gets to a certain point, before it perhaps even becomes clinically symptomatic, we can go back in. If you subscribe to the belief, and I think we can all subscribe to the belief, that MS is by and large a progressive disease. And so it'd be nice to have this imaging follow-up so we can get in there and preserve the healthy venous flow, decrease the abnormal venous hypertension in the intracranial venous vasculature in order to prevent whatever progression of the disease there might be. And what that is, we don't know yet, but this is really why we're sitting here talking today, isn't it?
Exactly. At the same time, you want to be able to maintain the quality of life of the person with MS too. You don't want to have that sort of nerve-wracking relapse now.
Like we were just talking about a moment ago, you have a good month and then you have a bad day, and it's very frustrating and very probably unnerving to you.
Absolutely.
And I would think that as an MS patient, knowing where you could go back to, you would probably want to do, within reason, whatever you could to go back to that place.